Hello, I'm Rafael Mazuz with Diligence Wound Care Global. We're here with Kara Couch from George Washington University Wound Care Program, and also, of course, the Secretary of the AAWC, the Association for Advancement of Wound Care, many other titles and roles and
A few hats
in this industry. We're just wrapping up here the AAWC Pressure Ulcer Summit here in Atlanta. Was a great 2 or 3 days of collaboration, technical and workshops, voice of the patient, continuum of care, some operations and administration and billing type stuff. Really kind of checked off all the boxes for what looking for the conference as far as I'm concerned. What are your thoughts on
We're thrilled. We really wanted this conference to provide the most evidence, but also the most practicality. What are people going to be able to do when they get back to their clinic on Monday morning? There's a lot of conferences that you can go to where you don't have a really strong take-home message or anything that you can apply. It's maybe you've gotten some concepts shifted or something like that, but we really wanted to focus on getting everyone speaking with the same voice and focusing on the most important person, which is the patient, which is why we had all of the patients and
That's beautiful.
as speakers.
And you had quite a few actually international representatives. I'd say more than you usually see in a typical U.S.-based conference. Of course, in other countries, it's very international typically. How was that important to you as part of the planning committee? And how did you see that play out? And what do you feel that added to these last 3 days?
Well, we have collaborating organizations that work with us who have the same mission in that they're caring for people with wounds, but they're doing it in other countries. We are partnered with the European Wound Management Association, with AAWC, which is the Mexican Wound Care Association. I do not know the long acronym, something Asociación. And in the past, we've worked with Wounds Canada, but they're fighting the same battles. And so we have different issues from a regulatory reimbursement strategy, but if they're taking care of patients in Switzerland who have the same comorbidities but they're getting better outcomes, we need to know how they're doing it, because we need to start doing that here. We can't say that we're providing the best care in the world if we don't know what the world's doing.
Beautiful. Yeah, that's a really good point. And I think for the attendees, that collaboration was well seen, and it was threaded throughout. It wasn't just an international session.
Yeah.
They had it in different sessions incorporated, and I think that was a really nice perspective. So I kind of grew up in the post-acute wound care setting, hospital-based wound care centers, but managing outpatient facilities that work with skilled nursing facilities and the inpatient. You kind of have a role that's inpatient and also outpatient, not only through your leadership capacity, but in your actual George Washington University hospital. Could you speak a bit to maybe how you've seen those settings evolve in terms of collaboration, in terms of how the hospital administration sees them? I remember often the outpatient center was seen as revenue because you're seeing patients and making money, usually more than you're spending. And the inpatient often would be seen as a cost because they're not making more money from those patients. I feel like it's been balancing a bit more, where it's more collaborative and kind of working together. What's your experience in that?
Well, I would agree with that, and I think that it's also changed. I've been doing wound care as a nurse practitioner for 16 years now, which time flies when you're having fun. But at my first job, I only worked outpatient and did that for 7 years, and there was an inpatient team that focused on probably more pressure ulcer preventions, but they weren't necessarily taking care of our wound center patients. That was being taken care of by the inpatient surgical wound service. When I went to Walter Reed, there was a difference where we were all in the same group, umbrellaed out of general surgery, but we did inpatient and outpatient. And I really grew to appreciate the continuity of care that the patient receives when they meet me on the inpatient side. I already know who they are, I already know what procedures they had, what's going on, and then I'm going to follow them up as an outpatient and go from there. So, I think the patients also appreciated that. And then we took that concept when I went to GW and expanded that. And it not only helps to mentor and empower the inpatient nursing team who maybe wasn't as familiar with sickle cell ulcers as I was, because that's primarily an outpatient problem. They don't get admitted for their ulcers as much as a crisis. But really to get everybody working together. And so when we have our patients admitted to the hospital, we look at the list, and if it's someone that's already come from the wound center, I don't need to bring a new provider into their care unless I need a consult. They already know, I know what's going on. I probably know their personal preferences, because patients have, things that they don't want their dressing applied this way. They don't want this tape or whatever. Why should I dump that on someone else who has to then build trust and gain a relationship with that patient when I already have one, when we're all working from the same team?
That's a great point.
So by integrating the inpatient and outpatient wound services, we have vascular surgery, podiatry, advanced practice nursing, and our wound ostomy continence nurse specialist all working together, and we look at the patient and see what it is and triage amongst ourselves. And then if I get a phone call from a service that it's not my primary patient that I'm following, I don't turf it. I take the information in, I share it with my colleague, and then they will answer it back, but it just creates a much more harmonious environment. And again, the patient is the winner of that environment, in my opinion, because you're creating a single stream of providers and care for the patients, rather than saying, no, I don't own that problem, that's on the heel, that's a podiatry problem, no, that's on the butt. Like, we share patients back and forth.
That's wonderful. So I guess that's almost like the next evolution of not just having an interdisciplinary team in the wound clinic, like infectious disease Monday, plastics on Tuesday, endocrinology on Wednesday, but actually sharing it across different care settings in addition to the different specialties.
I think so, and we have plastic surgery come in now to, again, trying to bring everything to the patient in our center, because it's so challenging to get them out to other places, and they'll do, their evaluations there. We can get vascular in, and so we try to centralize the wound center as the hub of all the activity for the patients when they're an outpatient.
Now, of course, the most important thing is the patient care and the clinical care. In that sense, how have you seen that drive maybe other operational things, like how new products are introduced or selected based on that kind of cross-continuum team, or other protocols when you have inpatient, outpatient, and the community working together?
Well, I think that there's always formularies. However, when's the last time someone looked at your formulary on your inpatient side? I look at it on my outpatient side a lot more closely, because that dollar stream, you're only budgeted for so much. However, when I go upstairs and I look in my inpatient supply closet, I have 7 different kinds of tape. Why do I have 7 different kinds of tape? I don't need 7 different kinds, not to mention the sizes, but if you create a very streamlined formulary where you're using the same products, inpatient, outpatient, this is just my personal opinion, you then are much better at educating everyone else who has to do the wound care, the frontline nursing staff, the ER residents, the medical students, the nursing students, the physical therapy students, everyone that comes into our environment in an academic medical center, and really can get people to understand what we're putting on the wound and why, and that it matters.
So better for the clinicians in training, even the non-wound care specialists. Yeah. Probably better for some of the patients when they have to go home, or they get the same products throughout the continuum. Might I also suggest the purchasers who have to negotiate pricing are probably very happy that they have everyone on a similar formulary, because then they get better pricing. And I would think that a lot of the industry enjoy that as well, because it costs them a lot of money to send a rep to sell you 1 box of foam dressings every month. Yeah. And that's not even worth the time that they spend on that rep. So they'd probably rather you use more of their things across the whole system or the whole hospital, and then they can go all in supporting and training you.
Well, it's kind of like the Swiss cheese theory, where you say, I just want to bring in this one product, but I'm going to trial it only on this floor. The patient's not going to stay on that floor. So then that patient goes to another unit who doesn't know what that product is, and then they get confused and it gets thrown away. And so then you need to have more of a system-wide saturation. And then, of course, there's going to be one-offs. There's going to be specialty items that are only in intensive care units, the ORs, what have you. But for the vast majority of things, if you create a much more standardized approach, I think that you can reduce waste. People really understand what's going on, what things are supposed to be used for, and how, and then you can look to maybe freeing up some money to get some more bells and whistles, gadgets, technology that you probably didn't have the opportunity to do because you were wasting so much money on ordering things that weren't ever going to be used and weren't being used appropriately in the first place.
That's a great point. So, all right, so we talked about the clinical continuity or collaboration across care settings. We talked about the products and therapies and how there can be benefits, knowing that each site has their own needs. Some are more outpatient or ICU, as you mentioned, but as to what extent possible to streamline. What about the metrics and the KPIs? I know that's something you've championed in your facility. Again, putting on my outpatient clinic hat, I feel that a lot of the influence of the outpatient centers over the last 10 to 15 years have been because they did a pretty good job of coming with KPIs, the average days to heal, the healing percentage, and financial metrics. This is our profit, this is our revenue, expense, this is the percentage, the average cost of a dressing change. And those are things that hospital leadership, hospital administration can understand and relate to. And then they kind of treat it like a real thing that you can invest in it and then improve those KPIs.
Yeah.
Or, we added a nurse and we improved the healing rate by 20%, stuff like that.
Yeah.
How much, when you are championing that in the inpatient, those metrics and KPIs, how much of that is driven by wanting to be able to give that kind of a message to administration? And how much of it is just because that's how you feel that you want to just improve the quality of care overall?
Well, I'm fortunate in that my hospital administration recognizes skin health as a priority for our hospital and is supporting our efforts. And they're putting their money where their mouth is. So it's not just a verbal commitment. We are investing in technology that's going to assist us system-wide with doing appropriate and immediate identification of issues when the decision is made to admit them to the hospital. We will be examining all of their wounds using the same system, so we won't have any of the inter-rater reliability problems with, we only measure wounds on a Wednesday, but the patient got admitted on a Thursday, and so it's going to be 6 more days before it gets measured because that's not what the policy says. So everything will be measured digitally, objectively, and then can be tracked longitudinally, which will already help us. And that way, if we have some questions or perhaps the documentation on admission wasn't as crystal clear, if we have a digital image to back it up, that was this present on admission or did this happen after the patient was admitted in our care, it helps to clear up that incredibly. And when you have a patient that gets admitted to the hospital who has 20 pressure ulcers present on admission, which unfortunately that happens.
Sure.
Doesn't happen all the time, but you're spending an hour measuring and documenting all of those locations, and then you have to go back to your chart and put all of that in. That takes another 45 minutes just to input that correctly, whereas if you had technology where you could take an image, it zooms to the cloud, and then it zooms into the chart, and then it's done, you're saving everyone time and energy, and then you can go see the next patient and move on, and it's much more efficient.
That's a great point. So how do you, once you finish implementing that digital technology, how do you foresee your discussions with the hospital C-suite changing or evolving? I mean, I'm sure you're discussing, of course, hospital-acquired pressure ulcers and surgical site infections and things that everyone is looking at. Do you see that broadening the kind of topics that you're able to discuss with that data?
I think so. It gives us a better volume of data for gap analysis and for missed opportunities, and also how can we improve and move forward. And I think that there's different ways to leverage the technology to look at clinical decision support. In addition, helping with staging accuracy and things that have really confounded, not just physicians, nurses, physical therapists. Like, it's a very confusing system that we're stuck with right now, for better or for worse. But if we can streamline the process and get everyone looking at the same thing, and also then using the technology to improve education, we're only going to keep empowering our frontline staff. And I think earlier identification leads to more prevention and fewer hospital-acquired conditions.
Beautiful. So from where you sit, where do you see the next unresolved kind of challenges in wound care? Are there certain products that are needed? Is it an educational piece? We talked about digital, or is it something else that in 5 years from now that you would like to see empowering clinicians?
So I think that we have not fully evaluated and deployed how to use compression appropriately. And I have so many patients who have, I work in the District of Columbia. We have a lot of patients who have had a lot of trouble with substance abuse, IV drug abuse, and did skin popping and now have horrific, just blown out their venous system. But it's not just the venous system, it's the lymphatic system, and being able to treat that in a combined manner.
And many of them are not so old either.
They're not old. They're in
yeah.
their 40s and their 50s.
So they
they're
got a
not. They're
long way
clean. They
to-
have a long life to
deal with
live
that, yeah.
with a lot of chronic conditions. We don't have as many certified lymphedema therapists as we need. I mean, the waiting lists are always forever. But integrating all of these pieces into the wound center, I think, is what is important, because everything is still like, oh, you have to go here, together. We put all these burdens out there. I don't know how to do lymphatic decongestive massage.
Yeah.
But I'd like to learn. But if I had someone in my clinic that could teach, and we could just, have all of the right pieces together, and recognizing that, these are chronic diseases that these patients are going to live with. We very rarely do I heal someone and say, I'm probably never going to see you again. That's usually a result of a trauma or an venous ulcer, diabetic foot, pressure ulcers. I'm going to see them again. So we need to stop wiping people out of our system the second we deem them healed, because they're going to be with us. And we need to be focused on, I'll see you in 3 months for your prevention check, and go from there, and not just saying goodbye to them, knowing that they're going to be back.
That's great. So kind of bringing some of these other related wound care specialties under the umbrella, instead of having to kick them somewhere else where you're blind to what's going on, as well as more prevention and longitudinal care of those patients. Wonderful. Well, Kara, this was, from my perspective, this was a really great conference. I know a lot of the attendees got a lot out of it. And thank you so much for your time.
Thank you so much.
Okay, appreciate it.
Appreciate it.